The skin is the largest organ in the body, and acute inflammation or disruption of skin function can have serious and sometimes even life-threatening consequences. So in this talk, we're going to talk about the concept and the consequences of skin failure. We'll talk about erythroderma, where there's extensive inflammation of the skin. We'll cover erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis, some of the most important and life-threatening conditions that affect dermatologists. We'll talk about other severe drug reactions, particularly drug reaction with eosinophilia and systemic symptoms, and AGEP, acute generalized xanthematous pustulosis. We'll cover severe urticaria, angioedema, and anaphylaxis. We'll cover vasculitis, some of the neutrophilic disorders, particularly Pyoderma gangranosum. Other severe infections which are life-threatening, such as eczema hepaticum and necrotizing fasciitis. These are covered in other modules. Skin failure is usually the result of a widespread acute inflammatory dermatosis, such as eczema, psoriasis, drug eruptions, but it can occur due to widespread skin blistering. And it results in the inability of the skin to perform its key functions of temperature homeostasis, preventing fluid loss. So in the normal course of events, we lose about 400 mils of fluid across our skin every day, excluding sweat. But when there's acute inflammation of the skin, fluid loss might be up to 3 litres a day. The barrier integrity is broken down. So this can result in pyococcal infections with staphylococci, streptococci, and pseudomonas. In skin failure, there is often hemodynamic instability due to the greatly increased amount of blood flow through the skin, and this can produce hypotension and high output cardiac failure. There is metabolic instability in skin failure. One enters a catabolic state with huge demands on calories. We may become hypoalbuminemic, producing edema, mainly due to loss of protein in scale. There are frequently hematological abnormalities, particularly neutropenia and lymphopenia in skin failure. So what causes skin failure? Largely it's due to erythroderma, which is defined as an inflammatory condition affecting 80% or more of the surface area of the skin. So this can occur in erythrodermic psoriasis, in eczema. It can occur as a result of drug reactions, skin lymphoma, HIV, and a condition called pityriasis rubra pilaris. There are other rarer causes of erythroderma, but this covers the vast majority. Skin failure can occur when there is widespread blistering. So this can occur in immunobullous disorders such as pemphigus, occasionally pemphigoid, and drug-induced blistering, which results in Stevens-Johnson syndrome or toxic epidermal necrolysis. So here's an example of erythrodermic psoriasis. The history is of long-standing stable plaque psoriasis, but he was given for a presumed fungal infection the drug terbinafine, and this is well known to produce exacerbations of psoriasis. So from being small plaques of psoriasis scattered over his body, the whole of his skin has become red, scaly. He feels ill, the skin is sore, and he's shivery, and he's got a tachycardia, and his skin feels hot, and this is sometimes termed the radiator sign. There's so much blood flow going through his skin that his skin is radiating heat. Here's another example of skin failure, a very elderly lady who had been complaining of blisters affecting her skin and the mucous membranes of her mouth for the last 2 months. The rash has been inexorably spreading and now is covering more than 80% of her skin surface. Again, the skin is sore, she's shivery, she's got a tachycardia, and she's hypotensive. All features of skin failure due to pemphigus. Here's another example of acute skin failure due to toxic epidermal necrolysis. So this man was started on lamotrigine for epilepsy 20 days ago. 4 days ago, he suddenly developed widespread redness and sores in his mouth, on his genitalia, and his eyes were red and sore. Large sheets of epidermis have been shed, revealing denuded epidermis, and you can see this over his back. He's in agony, he's unwell, he's got a tachycardia, a fever, and he's hypotensive. And unfortunately, he died 4 days later despite intensive ITU support. And here's a final example of acute skin failure, and this is due to generalized pustular psoriasis. So this man has had long-standing plaque psoriasis, but his skin's got very much worse in the last 4 weeks. He's red all over, and all over his skin there are masses of pustules, as you can see in this image. The pustules are sterile, bacteriology didn't grow any bacteria. He's febrile, he's ill, and he's got a tachycardia. All features of acute skin failure due to generalized pustular psoriasis. So the general principles of managing skin failure are as follows. Temperature control. Patients should be nursed in a warm room. If necessary, they can have a space blanket, and it's absolutely essential to watch for the development of hypothermia. They need fluid replacement, and this may be either intravenous or enteral. They're catabolic, and they need lots of calories and high protein intake as well. Again, this may require either enteral or occasionally parenteral feeding. It's important to watch for sepsis. Clues to that are going to be tachycardia, hypotension, leukocytosis, elevated CRP. So in anybody who's got denuded skin, it's important to consider reverse barrier nursing to give the patients the best chance of not acquiring a hospital-acquired infection. It's important to use emollients to protect the skin barrier function and hopefully reduce transepidermal fluid loss. And then, of course, specific treatment is required for the underlying etiology. This may be topical, but very often this is systemic therapy. So, for example, this may be for generalized pustular psoriasis, acitretin, methotrexate, or biological therapies. For severe eczema, oral steroids, cyclosporin, or biological therapies. So, in addition to the general principles, specific treatment for the underlying cause is required. Erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis represent a spectrum of disorders, with erythema multiforme being the mildest and toxic epidermal necrolysis being the most severe and occasionally fatal. And the conditions often overlap and merge into one another. Erythema multiforme affects the skin only, so lesions tend to occur acrally on the palms and soles with triphasic target lesions. Stevens-Johnson syndrome, the erythema multiforme, is often more extensive, but is accompanied also by mucosal lesions. So these are blistering and erosions affecting the nasal mucosa, the lips, mouth, conjunctivae, and genital mucosae. Toxic epidermal necrolysis is the most severe end of the spectrum, so there'll be both mucosal involvement, but also very extensive skin involvement with necrosis of large areas of the epidermis, revealing denuded dermis below. Here are some of the typical clinical features of erythema multiforme. So on the upper left-hand panel, you can see the typical triphasic target lesions that we see in erythema multiforme. Note there's a central blister, then a zone where there's pallor, and then a zone where there's elevation. So triphasic target lesions. And these commonly occur on the palms and soles, and then with more severe disease may be evident more proximally. On the right-hand panel, further lesions, targedoid lesions, this time not quite so typical. In Stevens-Johnson syndrome, as you can see in the lower panel, there's very often involvement of the nasal mucosa, the conjunctiva, but particularly the mouth and lips. So there's erosion, soreness, oozing, particularly from the lips. The clinical picture of erythema multiforme is often that of the sudden onset of lesions affecting the hands, feet and trunk. These are typical triphasic target lesions, as we've just seen. The condition lasts about 7 days before settling. Erythema multiforme major or Stevens-Johnson syndrome, in addition, tends to affect the mouth, ocular and genital lesions. So what causes erythema multiforme and Stevens-Johnson syndrome? Often we don't elucidate an underlying cause, but some of the best known triggers are herpes simplex infections, and one of the problems is that these can sometimes be recurrent, and people will get an attack of erythema multiforme each time they get a cold sore. It can be triggered by cytomegalovirus, Epstein-Barr virus, by chickenpox, by hepatitis A, B and C. So it tends to be a reaction pattern, particularly to viral infections. However, it can be triggered by mycoplasma, can be triggered by fungal infections, and may well be triggered by drugs as well. Toxic epidermal necrolysis, however, is almost always caused by drugs, but occasionally it is seen in the setting of acute graft versus host disease, but the vast majority of toxic epidermal necrolysis is due to drugs. Both toxic epidermal necrolysis and Stevens-Johnson syndrome are relatively rare, anywhere between 1 and 3 cases per million population per annum. But they're obviously very important conditions to recognise. There are certain conditions which might predispose towards toxic epidermal necrolysis. So it's more common in individuals who are infected with HIV, when it may be 1 per 1,000 population per annum. Toxic epidermal necrolysis is more common in patients with lupus erythematosus. And as mentioned previously, TEN can be part of acute graft versus host disease. As mentioned, toxic epidermal necrolysis can be a very severe condition, and the overall mortality is anywhere between 30 and 40%. This is an example of Stevens-Johnson's toxic epidermal necrolysis overlap. So the patient started with perhaps more typical target lesions, but these have spread, producing more widespread atypical target lesions, sometimes with the development of hemorrhagic macules, and as commonly occurs in target lesions, there's central blistering. So this is Stevens-Johnson's toxic epidermal necrolysis overlap. These are some of the early acute changes of toxic epidermal necrolysis. There's widespread, extensive redness, localized blisters, and erosions affecting both the skin and the mucous membranes. So his conjunctiva were red, and again you can see the crusting and oozing from his lips, and the whole of his oral cavity was eroded and blistered. This shows some of the later features of toxic epidermal necrolysis. The redness has become more vivid, and there's detachment of full thickness epidermis from the dermis below. And the detached epidermis often folds, producing what is sometimes referred to as the wrinkled wet wallpaper sign. In addition, the patient's ill, febrile, and gravely ill. Here's a image of somebody with extensive toxic epidermal necrolysis, but this concentrates on the mucosal lesions. Again, look at the hemorrhagic lips, the extensive loss of epidermis on the tongue and inside the mouth, and blistering may extend down both the upper and the lower airway, and this can sometimes produce acute respiratory obstruction requiring intubation and aspiration of the denuded mucosa. There'll be genital erosions and conjunctivitis and conjunctival erosions too. Toxic epidermal necrolysis has a significant morbidity and mortality, and this can be predicted by something called the SCORE-10 score, and this should be done within 24 hours of a patient being admitted, and it will predict the mortality that can occur in toxic epidermal necrolysis. So various parameters are scored: the presence of malignancy, heart rate greater than 120 a minute, elevated glucose level, elevated urea, reduction of the bicarbonate, a body surface area greater than 10%, and age greater than 40. And the scores are summed up, and this will predict the chances of mortality and death occurring in the affected individual. There is one important differential diagnosis that can look very much like toxic epidermal necrolysis, and it's called staphylococcal scalded skin syndrome. And this is a condition which occurs often due to a distant staphylococcal infection, either due to an abscess or a wound infection, but the wound is infected with a staphylococcus which produces something called an epidermolytic toxin. And this produces sudden widespread redness, and then it produces very superficial blistering within the epidermis. So this is blistering just below the granular layer, in contrast to toxic epidermal necrolysis, where there is full thickness epidermal necrosis. The other feature of staph scalded skin is that the mucous membranes are unaffected. So you can see it looks rather similar with the redness and the wrinkled wallpaper, the wrinkled wet wallpaper sign, but there are no mucosal lesions. So the general principles of managing toxic epidermal necrolysis are they need to be admitted, ideally to either a Burns unit or an ITU. Really important to immediately establish and remove any putative cause by way of drug. Obviously, it's essential that forever they avoid that drug and avoid any potentially cross-reacting drugs. And it's essential that they're eventually supplied with a medical alert badge, because if someone presents with toxic epidermal necrolysis and they survive, if they have the drug again, they will probably succumb to toxic epidermal necrolysis. Here is a list of the most common culprit drugs as of 2022. Sulfonamides, carbamazepine, phenytoin, valproic acid, oxycam, non-steroidal anti-inflammatory agents, allopurinol, possibly even corticosteroids, lamotrigine and sunitinib, one of the EGRF antagonists, a chemotherapy agent. So these are the common culprit drugs at present. Patients with toxic epidermal necrolysis should be in a situation where ventilatory support can be given if respiratory failure occurs. This can occur due to both parenchymal lung disease and also due to shedding of the bronchial and tracheal mucosa, producing obstruction of the airways. Survival is largely due to intensive nursing support in an ITU. Patients need to be reverse barrier nursed. They need repetitive swabs, so a swab taken every day, so if they become unwell and septicemic, you've got an idea of what the most recent bug that was growing on the skin is. wounds should be cleansed, often using a silver-containing antiseptic, and the denuded areas can be dressed with non-adherent dressings. Often patients are nursed on fluidized bead beds. The epidermis can be left in place as it will act as a biological dressing, but if it becomes dry and crispy, then it can be gently removed with scissors. Obviously, patients need fluid replacement and either enteral or, if necessary, parenteral nutrition. Patients require analgesia, usually with opiates, and they need eye and mouth and genital mucosal care by appropriate specialists. There is still great debate as to whether any specific treatments actually help. However, it's not uncommon for clinicians to give a short course of methylprednisolone in very early progressive disease, but it's important to withdraw this as soon as possible because of the potential side effects of steroids. There's some evidence to suggest the benefit of using a short course of cyclosporine. There's further controversy regarding the use of intravenous immunoglobulin in toxic epidermal necrolysis, with evidence to suggest some benefit, evidence to show that it doesn't help. The second severe drug reaction we'll discuss is called drug reaction with eosinophilia and systemic symptoms, which is usually abbreviated to DRESS. Again, it's uncommon but potentially life-threatening. It's sometimes called the drug hypersensitivity syndrome. It's characterized by a rash which is rather non-specific, and it's usually associated with fever, pharyngitis, and cervical lymphadenopathy. One of the features that is quite commonly seen is that patients will complain of facial edema. So that is one of the clues to this underlying diagnosis. Patients have usually got a peripheral blood eosinophilia, and importantly, they may develop hepatitis, nephritis, or pneumonitis. If the condition is survived, then about 10% of patients will also develop hypothyroidism. And DRESS has a mortality of about 10%. DRESS, of course, is due to drugs, but interestingly, it tends to have a relatively late onset. So the condition starts between 20 and 60 days after the drug is initiated, and that's often why it's not considered as a potential diagnosis, because patients have been taking the offending drug for quite a long period of time before the rash and symptoms develop. So the rash is relatively non-specific, tends to occur on the abdomen, trunk, back and limbs. But very commonly there is redness of the face, and the patients will often complain of facial edema, which may not be that evident if you've met the patient for the first time, but it's something often the patients will notice themselves. So the important thing about DRESS is to stop the offending drug and start them on oral prednisolone. The standard dose is anywhere between 0.5 milligram per kilogram a day, and they'll probably need this for a couple of months. The reaction pattern may be familial, so it is important that other family members are warned that they're at greater risk of developing DRESS with drugs. And obviously, if people survive the condition, they should have their thyroid function tests checked on recovery. Pneumonitis is a life-threatening condition, and there have been cases where liver transplantation has been required because of DRESS-induced hepatitis. And here's a list of the culprit drugs. Anticonvulsants, particularly the aromatic anticonvulsants and lamotrigine, but it tends not to occur with gabapentin and benzodiazepine anti-epileptics. Other drugs that are well reported to produce stress are allopurinol, dapsone, minocycline, terbinafine and nitrofurantone. And again, to stress, these can have been exposed for 20 to 60 days before DRESS develops. Acute generalized exanthematous pustulosis, or AGEP for short, is the last severe drug reaction we'll discuss. There's a rapid onset of redness and pustules develop within the red area really rapidly after exposure to the offending drug. So it'll often start as early as 2 hours after exposure to the drug, but is certainly started by 24 hours. There may be associated fever and malaise, and over the course of the next 7 to 14 days, the skin will desquamate. It's usually a benign, self-limiting condition once the drug is discontinued, but a small proportion of patients will develop internal organ dysfunction, particularly of the liver. And here you can see a close-up of somebody with AGEP. There are myriads of pinhead-sized pustules in the affected area. Triggered drugs that are most notorious are tetracyclines, sulfonamides, calcium channel antagonists, carbamazepine and terbinafine. Next, moving on to urticaria, angioedema and anaphylaxis. Urticaria is a common condition which produces transient raised wheals on the skin. They're often accompanied by itch, and by transient I mean that they tend to last from minutes to hours, but by definition last less than 24 hours. Angioedema is similar to urticaria, but it is deeper and tends to affect the lips, tongue, pharynx, lids or genital mucosae. Anaphylaxis is a severe, potentially life-threatening reaction when there is hypotension, bronchospasm, as well as urticaria and angioedema. Urticaria is common, affecting 5% of the population at some time in their life. The wheals, as mentioned previously, are transient, lasting less than 24 hours, and they resolve without scale or weeping. Urticaria may be acute, or it may be chronic, and the definition of chronic urticaria is when urticaria is occurring on most occasions for 6 weeks or more. Urticaria may have a number of causes. The majority of chronic urticaria is idiopathic and autoimmune. Acute urticaria may be triggered by a variety of foodstuffs, the most notorious being shellfish, nuts, soft fruit, citrus fruits. They can be triggered by food additives such as colourings, preservatives and salicylates. Urticaria is not uncommonly triggered by bites and stings, and it may accompany a variety of intercurrent viral infections. Drugs are certainly a well-known cause of urticaria, and we'll dwell on this in a moment. Urticaria may be due to contact with certain substances. That's usually proteins and latex, and is an example of a protein that can produce contact urticaria. Finally, there are a number of physical causes of urticaria that would produce what is sometimes termed inducible urticaria, such as pressure, heat, rubbing, light, exercise. Angioedema can occur alone on its own or may accompany urticaria. Immediate angioedema may be the result of type 1 reactions to proteins, and this tends to occur within minutes or certainly within an hour of exposure to the offending allergen. Anaphylactoid reactions are usually due to radiocontrast media, and they induce direct mast cell degranulation. Again, these tend to occur within minutes or hours of exposure to the agent. ACE inhibitors are a well-known cause of angioedema. and they may only develop months or even years after the beginning of the ACE inhibitor treatment. And this is due to the effect that ACE inhibitors have on the inhibition of kinin metabolism. Exceedingly rarely, angioedema can occur in the setting of a condition called C1 esterase inhibitor deficiency. So this is usually an inherited defect of C1 esterase inhibitor, which allows unrestrained complement activation. And this results in particularly angioedema of the lips, of the tongue, as shown in the lower panel. And of course, angioedema can occur in the setting of any of the other causes of ordinary urticaria. These images show angioedema of the tongue and the upper lip caused by ingestion of ACE inhibitors. So if anybody is taking an ACE inhibitor and they develop angioedema, it's essential that it's discontinued, and anyone with a previous history of angioedema of any cause should avoid ACE inhibitors. This problem is more common in African Americans. Drugs can produce urticaria, angioedema and anaphylaxis by a number of mechanisms. Proteins can act as type 1 allergens, and they will cause in those allergic mast cell degranulation, histamine release, and hence urticaria anaphylaxis. So the proteins are often sera, vaccines, particularly those which contain egg, desensitizing agents, enzymes, and blood. Antibiotics are a well-known cause of urticaria. Non-steroidal anti-inflammatory agents and aspirin often exacerbate or induce urticaria by pharmacological mechanisms. Narcotics can produce urticaria, and radiocontrast media can produce anaphylactoid reactions by producing direct mast cell degranulation, as can muscle relaxants used in anesthesia. Anaphylaxis is a medical emergency. Affected individuals develop acute hypotension, wheeze, confusion, and may have angioedema of the tongue and pharynx and urticaria. This can then progress on to collapse and ultimately death. And this occurs rapidly after exposure to the causative agent, and deaths can occur within 15 minutes of exposure to the offending allergen. So it's managed by immediately giving the patient oxygen and intramuscular adrenaline, as well as chlorpheniramine, hydrocortisone and fluids. But of all of the agents given, adrenaline is the most important. In the next section, we're going to cover the basics of recognising vasculitis and vascular occlusion. In small and medium vessel disease, occlusion can occur due to inflammation of the blood vessel wall. So this is a true vasculitis, in which there is noted the presence of inflammatory cells within the vessel wall and fibrinoid necrosis. This is to be contrasted with a condition called occlusive vasculopathy, and in these conditions, various things may obliterate the blood vessel, preventing the perfusion of blood through it, and this can be occluded by clot, by emboli, by calcium, cholesterol, or cryoproteins. Firstly, in thinking about vasculitis, the majority of vasculitis that is seen in dermatology is purely a cutaneous disease, but of course it is important with vasculitis to make certain there's no evidence of any internal organ vasculitis, particularly affecting the kidney, the lung, the gut and the central nervous system. Finally, large vessel vasculitis will show some examples of this, particularly temporal arteritis. The hallmark of small vessel vasculitis is palpable purpura. So this tends to most commonly occur on the feet around the ankles and on the lower calves, but it can occur in other areas as well, such as on the buttocks and on the arms. So the lesions are purpuric and they're palpable. This is in contrast to, for example, thrombocytopenic purpura, which tends to be impalpable. And when there's more severe vasculitis, again, this tends to be most dramatic on the lower legs and feet. Not only is there extensive palpable purpura, but there may be blistering and ulceration as well. So what are the causes of small vessel vasculitis? Well, perhaps the most common is Henoch-Schönlein purpura, more common in children, but certainly does occur in adults. We can then see small vessel vasculitis within urticarial vasculitis. We can see exercise-induced vasculitis and small vessel vasculitis associated with ANCA-positive disease. Some of the well-known triggers to small vessel vasculitis are drugs, bacterial infections, particularly things like subacute bacterial endocarditis, hepatitis B and hepatitis C. And then we'll also see other underlying diseases in which small vessel vasculitis may be part of the clinical spectrum in the skin, and they're conditions such as systemic lupus, rheumatoid arthritis, and dermatomyositis. As already mentioned, in assessing patients with small vessel vasculitis, we've got to ask the question, is this largely or exclusively affecting the skin, or are internal organs also affected? So, is the kidney affected? Is there evidence of renal dysfunction on blood tests? Is there microscopic hematuria? Is the lung affected? This will manifest as breathlessness, cough, and hemoptysis. Is the gut affected? This will tend to manifest as abdominal pain and sometimes even intussusception and melena. Are the joints affected? Is there stiffness and swelling that might indicate associated joint disease? So if there's pure cutaneous small vessel vasculitis, we manage this by, if possible, treating or removing the underlying trigger. Always important to elevate the legs because this will reduce pain and reduce the tendency to vasculitis. And compression would also help, but this needs to be gentle compression at first, and as there's improvement, stouter compression will be tolerated. Topically, we'd use a potent topical steroid actually onto the lesions of vasculitis, which will help. And in more severe disease, oral steroids with more chronic disease, disease-suppressing drugs such as dapsone and colchicine. And here are the appearances of somebody who's got a medium-sized vessel vasculitis. And this produces a condition called livido reticularis. This is a network-like appearance of the blood vessels in the skin. And very often this livido may be palpable. And if you biopsy these palpable areas, this tends to be the most sensitive site to find evidence of small vessel vasculitis histologically. And here's an example of a large vessel vasculitis. So this is an elderly lady who was unfortunately dementing within a nursing home, but her mental state seemed to be deteriorating, and then she developed an extending ulcer over the temporal area, as you can see in this image here. And this took about 2 months to get to this size. Unfortunately, because of her dementia, nobody noticed that also her visual acuity was diminishing. She'd got an ESR of over 100 and a biopsy of a temporal artery, confirmed temporal arteritis. And she was treated with oral steroids, and unfortunately her visual acuity didn't improve, but the ulcer completely healed. And finally, here's an example of an occlusive vasculopathy. So this is an elderly patient who was actually on anticoagulants and digoxin, and she developed incredibly painful extending ulcers over her leg. And on histology, you can see on the lower panel there that the medium-sized blood vessel walls have crystals of calcium within them. So this is a condition called calciphylaxis, and it prevents the flow of blood through the small arteries, giving rise to very painful ulcers. So an occlusive vasculopathy rather than an inflammatory vasculitis. The final skin emergency we're going to discuss is a condition called Pyoderma gangranosum. And this is an ulcerative condition. It presents with a rapidly growing, often painful ulcer, most commonly on the lower leg, but it can occur absolutely anywhere, including the trunk, abdomen, scalp and face. It's an autoinflammatory condition. It often starts with a minor injury, and then the ulcer extends out from that injured area. The margin of the ulcer is often purple and overhanging. Pyoderma gangranosum is associated with a number of other conditions, including inflammatory bowel disease, rheumatoid arthritis, particularly myeloid, blood dyscrasias and paraproteinemia. So here's two examples of Pyoderma gangranosum. Painful, rapidly extending ulcers in the left-hand panel on the ankle and the mid-shin. In the right-hand panel, this is an ulcer which is developed in somebody who's got Crohn's disease on the lower thigh. And look at the purple edge to the ulcer. That is one of the diagnostic clues to Pyoderma gangranosum. And as previously mentioned, Pyoderma gangranosum may develop in sites of injury to the skin. So this may be a physical injury such as a cut or a graze, or a surgical injury. So the picture of the lady on the left has undergone breast reconstruction after breast cancer removal. And in the grafted and surgically attacked sites, Pyoderma gangranosum has developed and spread out. In the right-hand panel, you can see somebody who's got Pyoderma gangranosum on the breast, and she developed shingles about 6 months previously, and the area of shingles never healed, and that's because she'd got Pyoderma gangranosum in the area where the shingles had been. Pyoderma gangranosum is managed by local wound care and the use of potent topical steroids both to the ulcers and the ulcer edges. Very often people need systemic treatments, which include systemic steroids, cyclosporin, TNF antagonists and IL-12/23 antagonists. So it can be a challenge, but also very rewarding to treat. So this finishes the brief overview of some of the dermatological emergencies which arise in everyday practice.